Good morning, everybody. This boot camp is going to be maternity, maternal newborn, and we're going to cover the basics of nursing fundamentals, foundations, for preparation for the predictor. So we're going to start with maternal newborn, and I'm going to pull up a PowerPoint that I made, go over some of the basic information that you need to know, and I will share the PowerPoint online on Teams for everybody so that you have it, okay? I am going to share my screen. And there we go. I'm going to minimize our faces and move us out of the way. All right. Maternal newborn, part one. So we are going to start with reproduction. And the reason I'm going back is because I have found that with some people in term 5, they tell me that term 4 was like whoosh, and that they don't necessarily either remember or really understood everything in it, each of its pieces that you really need to understand. So I'm just going to do a quick overview of reproduction, fertilization, and all that good stuff. All right, and let me make this a little bit bigger too. There we go. All right, so here we have the male and female reproductive system. And when mommy and daddy love each other very much, no, I'm kidding, JK. Anyway, when we look at the female, you have 2 ovaries, and that is where you have your eggs. Your eggs, you have from the moment that you are born. So you don't make eggs, but eggs will mature within the ovaries. And then once the reproductive age is reached, every month with alternating ovaries, an egg that's mature will pop out. And that's because of FSH, follicular stimulating hormone. Stimulates the ovary to, make the egg mature, pop out, and then the egg will travel out of the ovary and through the fallopian tube. Then if mommy and daddy love each other very much and their sperm comes up through the vagina, through the cervix, and they're swimming, swim. If a sperm and an egg meet, boom, you have fertilization. Okay, and then just to go over the male reproductive organs, you have the scrotum, and inside the scrotum, you've got 2 testes, and they're the male reproductive organs. They control testosterone, they control the production of sperm. There's the good old prostate gland, right? All right, so now when we look at fertilization, the male sperm contribute either an X or a Y. So really, daddy decides, not voluntarily, but what child is going to be a female or a male.
Hello?
Please mute yourselves. Please mute yourselves. Mute yourselves. Thank you. Anyway, and so daddy contributes either an X or a Y. Mommy, well, your eggs are just X's, and that's all there is to it, okay? Fertilization occurs in the fallopian tube, okay? Once fertilization occurs, that fertilized egg, which is now called a zygote, right, moves and is supposed to implant in the uterus somewhere around 6 to 10 days after fertilization. And it's supposed to implant, I'm going to go back to this picture again, up here in the upper 2/3 of the uterus. If it implants down low, then, and when we get to pathophys of things like placenta previa, you're going to have a problem later on in the pregnancy. So that needs to implant up in the 2/3 upper portion of the uterus, okay? Once fertilization takes place, there are 46 chromosomes, 23 sets, 23 from mom, 23 from dad. And so remember 23andMe. That's how I remember it. The 1st through 22nd have to do with your DNA sequence. The 23rd set is sex. So it's either an XX or an XY, okay? There you go. Pregnancy. Now these are things, the things that are highlighted are the things that you need to know for the boards, okay? Very specific, because the board's not gonna go crazy. Positive signs of pregnancy. Ultrasound, I do an ultrasound and I can see the fetus. I can hear the fetus, heart tones, and I can feel movement. And that's usually somewhere around 4 months. Quickening, is the term used for when mom feels the first fetal movement. That's considered a presumptive sign of pregnancy. So you got positive signs, probable signs, and presumptive signs. Isn't that fun? Positive signs means this is empirical evidence, beyond a shadow of a doubt, you're pregnant. Presumptive means, we're not real sure, but it could be. Probable means, yeah, you probably are. And the three things you need to know: Goodell's, Chadwick's. Let's talk about those two first. The Goodell sign is the softening of the cervix. So when you go see your obstetrician and they do an internal, they can feel that the cervix has now become a little softer, a little mushy. Chadwick's sign means that the cervix now has a bluish or purplish coloration to it. And that's because of increased vascularity, increased blood flow. And then amenorrhea, your period stops. That's a probable sign of pregnancy, okay? All right, to estimate the date of delivery, Nagel's rule, and you need to know Nagel's rule. And this is pretty easy. You just count backwards 3 months. First day of the last period. Subtract 3 months and add 7 days. And remember that during pregnancy, weight gain, 25 to 30 pounds, doesn't matter whether mom is diabetic before she got pregnant, or if she becomes diabetic, which is gestational diabetes, while she's pregnant. Doesn't matter. Weight gain is the same because there needs to be a certain amount of weight gain just to support that growing baby. Okay? Okay. From the 8th week through delivery, it's a fetus, right? At 12 weeks, the fundus, which is the top of the uterus, should be able to be palpated at the top of the symphysis pubis. It's right at that, right below your belly button, right where your hair begins. At 20 weeks, the fundus is right around the level of the umbilicus. At 36 weeks, the fundus should be felt at the lower border of mom's rib cage. Okay? Prematurity, it's when the baby is born before the end of the 37th week. And when we talk about gravida and para, gravida, how many pregnancies did the woman have regardless of the outcome? Para is the number of pregnancies that reached viability. So it doesn't matter if the baby was born alive or stillborn, the age of viability, and that is 20 weeks gestation. So para is the number of pregnancies that got to 20 weeks or more, okay? All right. So here's another little picture just to show the process. And so the egg gets released from the ovary, egg, boom, 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 egg meets the sperm, boom! And then it goes in, the zygote goes in and implants itself in the upper wall of the uterus, okay? Okay, so that's a normal pregnancy. Let's talk about complications. And again, the things that are highlighted, these are things you need to know. If the patient complains of painless vaginal bleeding at any point during the last trimester of pregnancy, that can indicate something called placenta previa. So again, if that zygote implants towards the bottom of the uterus or near or over the cervix, pressure as that fetus starts to grow causes placental insufficiency. So remember that placenta is really, it's the liaison between the fetus and the mom, right? You've got the fetus, the umbilical cord, which attaches to the placenta, and the placenta is literally attached to the wall of the uterus. The baby's oxygen, the baby's carbon dioxide that's getting disposed of, nutrients, all of these things have to occur utilizing the placenta, right? So if the placenta is getting pressure, that's going to be cutting off possibly oxygen or nutrients to the baby. So that's a problem. Now, painful vaginal bleeding, that is abruptio placenta. So what happens here is the placenta abruptly, that's where the name comes from, just tears away from the wall of the uterus, and it can happen like a part of it can tear away or the whole placenta can tear away. That's completely cutting off oxygen and nutrition. Here's some pictures to help you better understand. Here's a normal inside view. There's the fetus, there's the umbilical cord, there's the placenta in a spot where it should be. Here we have placental abruption, okay, which is where part of the placenta, see the blood in here? It's torn away from the wall. And then here, look at where that placenta is. It's right underneath the fetus's head. This is placenta previa. And so as that fetus grows, pressure, 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 you're going to have a problem. Okay? Now, pregnancy-induced hypertension, preeclampsia, which can lead to eclampsia. We'll talk about that. Preeclampsia is a new onset of both hypertension and proteinuria after 20 weeks of gestation in a previously normotensive woman. So mom never had high blood pressure, and now she's greater than 20 weeks pregnant, and her blood pressure is elevated. So how do we diagnose it? Systolic blood pressure greater than 140, diastolic greater than 90, and proteinuria, that's a +3 in a 24-hour urine. So that's one of the things that we look for, right? Because when blood pressure is elevated, what it's doing, one of the things it's doing is beating up the kidneys. And the kidneys will manifest this as spilling protein into the urine. And so that helps us definitively diagnose preeclampsia, which needs to be treated, and usually it's a beta blocker, okay? Eclampsia is when it goes a bridge too far. And now blood pressure has become so elevated that mom will have seizures. Okay? And with the seizures, we know the treatment is magnesium sulfate. Let's look at this next little diagram or chart here that I put here. So with eclampsia, I talk about the treatments for both preeclampsia and eclampsia. And really the ones that you need to know, labetalol is the most commonly used beta blocker to manage pregnancy-induced hypertension, okay? And then if we're talking about seizures, well, that's where we go to the magnesium sulfate, okay? And mag sulfate, when we're administering it, especially if we're administering it intravenously, can be administered IM, but usually it's IV. When we're administering, we want to make sure that the patient has the correct dose, enough to stop the seizures, but not too much where it's having such a profound effect on the nervous system that reflexes become sluggish, hypoactive, or even absent. If we are assessing our patient who's receiving mag sulfate, you want to make sure that you're assessing deep tendon reflexes. And if they are sluggish or absent, that means we need to stop the mag and administer the antidote, and that would be calcium gluconate. Okay? With me so far, guys? Here is the list of must-know medications. Mag sulfate, we just talked about that. It's an electrolyte. It's used to stop seizures, right? Calcium gluconate, that's the antidote. Pitocin, oxytocin. Your body makes oxytocin, okay? And, but we have a man-made oxytocin, which is called Pitocin. If you are not progressing in labor, or you're having contractions that are not enough to both efface the cervix and dilate the cervix. And real quick, I'll go over that. Effacement is thinning of the cervix, and then dilation is where the cervix begins to open up. And the cervix needs to dilate to somewhere around 10 centimeters, okay? If that's not happening, then we can give you Pitocin that's used to induce labor. It can also be used to control postpartum hemorrhage. Not the most common treatment, though. That brings us to methylgonervine. Methylgonervine is the most common treatment used for postpartum hemorrhage. It cannot be used to induce labor. It's dangerous for the fetus. But after the fetus is born and mom goes into a postpartum hemorrhage, then this is the drug of choice that is used to, make the uterus contract. Okay. Labetalol, that's the beta blocker that's used, LOL, right? Used to treat preeclampsia. And then nifedipine, which is a calcium channel blocker, is also used to treat preeclampsia. Both of these drugs, just think about it, beta blockers and calcium channel blockers, unlike the antihypertensive medications, which are your ACE inhibitors, your ARBs, and your aldosterones, they make your heart rate go down first and then your blood pressure, okay? So it's important to be monitoring the patient's heart rate and blood pressure when the patient's receiving beta blockers or calcium channel blockers, okay? All right. Expected findings, things that are quote unquote normal when someone's pregnant. There's something called cloasma. They call it the mask of pregnancy. And so it's a hyperpigmentation around the cheeks and the nose. Like it almost looks like the butterfly rash with lupus, but it's just a discoloration. Some pregnant women get that, no big deal. Linea nigra is a dark line that will appear later in pregnancy, and it goes from the umbilicus down to the mons pubis, disappears after the baby's born. Leukorrhea, make sure you know this one, okay? It's normal. It's a thin, either white or clear vaginal discharge. Normal, okay? Normal. Morning sickness, okay? There's a difference between morning sickness and hyperemesis gravidarum. Morning sickness is something that happens commonly, usually in the first trimester, the first 3 months. And it's usually when mom starts getting up in the morning and she'll start to feel just this nauseous feeling. Cracker, a little plain, dry, saltine cracker before she gets out of bed. Believe it or not, that's usually enough. Now, some women get morning sickness to the extreme, and that is hyperemesis gravidarum. Hyperemesis, lots of puking, gravidarum while you're pregnant, right? With this, there are usually some problems. So in other words, if you're vomiting to the degree where you're not able to keep anything down, either fluids or solids, baby's not getting nutrients, sometimes you'll even see weight loss and dehydration. That is usually, that's going to require a hospitalization, at least for IV replacement fluids, possibly nutrients, depending on how severe, okay? All right. And then that's where I left off. So let's pause for 1 minute. I'm going to stop my share, and I'm going to pause my recording. Okay, we're back, and I have a lot of good stuff to share with everybody. So let me share my screen, and let me clear my throat. This PowerPoint first, and get over here. Okay, labor. So the first stage of labor begins with the onset of labor, the loss of the mucus plug, and that is basically exactly what it sounds like. There's this plug that kind of plugs up the cervix, and it will just be expelled spontaneously. The cervix will start to efface, that means thin out. And then once the cervix is fully dilated to 10 centimeters, that's when second stage begins. And the second stage of labor is full cervical dilatation, old term, dilation, and ends with the birth of the neonate. The third stage of labor is after the baby's out, now you have to expel the placenta. And then the fourth stage of labor is postpartum stabilization, and that lasts about, give or take, 4 hours. And here we're talking about a normal vaginal delivery, okay? And so when we look at this little cheat sheet here, it gives you, and I'm going to put this up for everyone, this gives you the stages of labor again, and then it goes through fetal positioning, and then this handy dandy little thing, mnemonic device that's called veal chop. So if you remember veal chop, you're going to remember the different types of decelerations or accelerations during labor, okay? When we talk about labor and fetal positioning, usually there aren't a lot of questions. However, there are sometimes questions about the positioning, right, of the baby. So I want to make sure that you guys know what is the normal, or where should the baby be? Where should the baby be? So vertex, face positions, breech, which is bad, and then others, which are also bad. Vertex positions, these guys are the ones that are okay. In other words, the baby should be head first, okay? But then head first facing in which direction, right? So right occipito-anterior, left occipito-anterior, occipito-posterior. So in other words, if it's anterior, the baby is facing, to the right and front, or the left and front, or the right and back, or the left and back, or the baby's head is tilted, which is transverse, okay? If the baby's face down, which are the facial positions, that's not good, and that's really all you need to know. And then if the baby's breech means that either the butt, usually it's the buttocks, sacro-anterior, so you're looking at the butt, sacrum, that's coming out first, baby's head up, not good, okay? When we talk about this little acronym Veal Chop, what I want to do is I want to show you first a chart that's probably the best one that I could find about fetal heart rate monitoring. And here we go. There you go. So during labor, we are monitoring both the mom's contractions and the fetus's heart rate, okay? And so when you look at a strip, what you see is you see the strip here of the baby's heart rate, and down here, this is mom's contraction, okay? So when you see the line down here start to rise, up, 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 this is the beginning of the contraction, and it's getting stronger, 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 and this is where it starts to come down. Well, this one happens to be a strip of variable decelerations. See here is the contraction, but look here, right? So the baby's heart rate is decelerating or dropping, not at the beginning of the contraction. This happens to be at the end of the contraction, but there's not really a relationship to the contraction, right? Here, there's even less of a relationship. So it's an abrupt onset, right? And it's a drop of 15 beats a minute for 15 seconds or more, but less than 2 minutes. So variable decelerations are not good. Neither are early, neither are late. What you want to see is acceleration. So let me go back to that little veal chop thing again, because this is the best way to remember it. And when you sit down to take your predictor and your boards, with the boards, you will have a dry erase board given to you. So you can write anything down that you want to at the beginning of the test. Okay, the board is blank. When you sit down, if you want to write down veal chop, if you want to write down lab values, any of those things, you absolutely can. Okay, veal chop, variable deceleration, B, early, E, acceleration is A, and L is late. And then it tells you here, what's the cause, what's going on. Variable decelerations are usually a compression of the cord. Okay, and that can be nuchal cord. Nuchal cord, nuchal means neck. So that's where the cord, the umbilical cord, is literally wrapped around the baby's neck. And so it can be a nuchal cord times 1, nuchal cord times 2, times 3. What that means is how many times is this thing looped around this poor baby's neck? Cord compression, it's worrisome. Early decelerations, that's when the baby's heart rate drops right at the very, very beginning of mom's contraction. So the baby's not even under stress yet, but the heart rate is dropping. That's head compression. So the baby's head, for some reason, is getting squeezed. There's sometimes insufficient room in the pelvic area for the head to get through. And that's sometimes an emergency cesarean section. Acceleration, well, that's good, right? That's okay, right? And then late decelerations, that's a placental insufficiency. That's usually enough. If we see 2 or more late decelerations, it's usually going to be a cesarean section. That means that the baby's heart rate is dropping precipitously at the end of the contraction. Okay? And so I will put this cheat sheet up for all of you, so this way you'll have it. And let me go back to this PowerPoint. Couple things that you need to know, and I'm actually going to highlight these before I put this up. An amniotomy is a mechanical rupture of the membranes. When we say rupture of membranes, okay, what that means is the amniotic sac, okay? or the sac of water, as it's sometimes called. Okay. When your water breaks, if your water doesn't break on its own, we will do it for you. And they have a little hook-like device that literally goes in, it pops the membranes. Okay. Nitrazine strips, and this is one that you definitely need to know, and I don't know that we tell you this enough because this is more a board question than an ATI question. And this is used to identify amniotic fluid. So mom comes in, she's say 36 weeks or 37 weeks gestation, and she's just in for a follow-up, and she says, I don't know what's going on, but I feel like all of a sudden I can't hold my urine, like I'm incontinent. So your brain should go, is she or is she leaking amniotic fluid, right? So you can have a sudden burst of fluid, which is pretty common, right? It's like a waterfall. Oh no, my water broke. But you can also have a slow leak, right? And a slow leak means that there's some kind of a compromise in that amniotic membrane, and the amniotic fluid is just kind of dribbling out, right? Which is also not good. How do you figure it out? You use a nitrazine strip, and it's like a dipstick that we use for urine, and it will identify positively if in fact what it's touching is amniotic fluid, not urine. And that's important for you to know, okay? Let's see. We talked about the fetal heart rate monitoring. This is another chart that I found that I put into this PowerPoint that gives you head compression. You'll see the early decelerations, uteroplacental insufficiency, late decelerations, and then umbilical cord compression, the variable decelerations. And I feel like a picture really helps people understand what it is they're looking at, okay? And there is veal chop again, and it gives you exactly what the interventions are, okay? So that's that. Postpartum, after the baby is delivered, lochia rubra, that's the vaginal discharge. It basically looks like blood, and that's normal for the first couple of days after childbirth. And then lochia serosa, it's a serous vaginal discharge, and it goes from that red to like a reddish brown, to then like a brown, to then like a almost, like a pale yellowish, and then nothing. And that happens 4 to 7 days after the baby is born, right? So you have the lochia rubra, first 4 days, maybe, whatever. And then 4 to 7 days after that is when you have the lochia serosa. When you are assessing a postpartum patient, and this one I don't have in my PowerPoint yet, so I'm just going to kind of talk, all right? So after birth, the fundus of the uterus needs to meet 3 criteria. It needs to be firm. So when the nurse comes in and pushes on the abdomen, she's not doing it to be mean. She's doing it to feel for the fundus to make sure that it's nice and firm. It should not feel mushy. The term is boggy, okay? That's bad. The second thing is it should be midline. In other words, it should be right along lines with the umbilicus, right in the middle. If it's deviated either to the left or the right, that's a problem. And then the third criteria is it should be at the level of the umbilicus right after birth, and then progressively the fundus will move down below the level of the umbilicus, because what's happening is the uterus is supposed to be contracting. After the delivery is over, mom has given birth to the baby, placenta's out, the uterus is contracting to get back to its former self. There are things that can interfere with uterine contractions. The number one thing that can interfere is a full bladder, okay? If mom has a full bladder, anatomically, the bladder can actually put pressure on the uterus and not let it contract. So one of the first nursing interventions is get mom to pee. You're the nurse, you go in, you assess, and the fundus is midline. It's at the level of the umbilicus, but it feels a little boggy. Did you urinate? Get mom to urinate. Sometimes that'll do it. Breastfeeding. Breastfeeding actually stimulates the female body to produce more oxytocin. your own chemical that makes the uterus contract. And so when women breastfeed, one of the complaints, oh, I'm getting a lot of contractions. Good, right? That means that the oxytocin is being released and that the uterus is contracting and getting back to where it needs to be. Because if the uterus is not contracting, there's still some blood, okay? And part of the inner wall can start to actually tear away. That's a postpartum hemorrhage. And it can happen quick, right? And so cardinal signs of a postpartum hemorrhage are back to the uterus, right? One of those three things or more is not present. So either the uterus is boggy, bad, or the uterus is above the level of the umbilicus, bad, or the uterus is deviated to the right or the left, bad, okay? And so you're assessing mom's lochia. You're assessing the pad, the perineal pad. If a perineal pad is saturated with blood more than every 30 minutes, like 30 minutes or less, or that's a problem. That means mom is bleeding. Also clots, you're assessing for blood clots. If you are visualizing mom is expelling blood clots onto these perineal pads larger than about the size of a quarter, that's a problem. Because if the clots are coming out, then they're not inside the uterus helping to make the bleeding stop. That makes sense, right? So that's a problem. And then the other thing is with any kind of blood loss, a patient can go into hypovolemic shock. And the first cardinal signs of a patient going into shock, the tachycardia and hypotension. The heart rate will start to increase because the body is saying, wait a minute, where's our blood? We don't have enough blood. That means we don't have enough oxygen. Heart, beat faster. And so heart rate will suddenly increase. But meanwhile, there's not blood volume because she's bleeding. Blood pressure will plummet. So when you see tachycardia and hypotension, your brain needs to think blood loss, hypovolemic shock, what is happening, okay? And like we talked about with the meds earlier, the treatment usually is methylgonervine. Now, if in fact you suspect, you're the nurse caring for the patient and you suspect that she's having a postpartum hemorrhage, yes, you massage the fundus. And I always ask students, how long? And they'll say, I don't know, 15 minutes. No, you put your hand on the fundus and don't take your hand off of it until you get some help, right? Because otherwise, I'm telling you, when people died during childbirth back in the day, this was one of the biggest reasons why. Mom would just bleed out afterwards. So you massage the fundus and you don't stop until help comes and the drug is administered, like methylgonervine, IV fluids are administered. If mom has an IV already with IV fluids, wide open to replace lost fluid volume, okay? Turn that IV wide open. And while you're help, room 214 or whatever, okay? All right, so that's postpartum hemorrhage. Let me take a pause real quick because sometimes people have questions about this. Okay, we're back. So now we have a baby. There's a baby. What do you do with the baby? Well, the first thing that you do is you must dry the baby off. You know, if the baby comes out bloody, kind of mucousy and wet, wet baby can get really cold really fast, right? So you want to dry the baby off, and we're doing an APGAR score. APGAR scoring is a test that we do at 1 minute after birth and then again at 5 minutes after birth to determine the breathing, it's cardiovascular basically, and pulmonary assessment. I'm going to share my screen and I'm going to show you a great cheat sheet for APGAR score. Okay, here we go. And so what you're looking at first, and this is what APGAR stands for, appearance. What does the baby look like? Pink, right? Torso and extremities. Pink torso, but the extremities are blue, or is the baby just blue? And you see the score, 2, 1, or 0. What's the baby's pulse? Is it greater than 100? Is it less than 100? Or is there not a pulse? Hopefully that's not what's happening, right? And by the way, FYI, heart rate for a newborn, for a fetus, somewhere around 110 to 160 beats per minute. Littler things have faster heart rates. Okay, just remember it like that. The littler the thing, the faster the heart rate. A hummingbird, I forget, it's like, I don't know, like 1,000 beats a minute or something crazy. The G stands for grimace. What does the face look like? Is the baby, vigorous cry, limited cry, or is there no response to stimulus? And when we talk about stimulus, stimulus for a newborn is not the same as what you would do for somebody who's an adult. So if the baby is not crying spontaneously, you don't slap the baby on the ass, which is, I know they show that in movies all the time. That's not real. You can flick the bottom of the baby's foot, the most common thing to do, boom, like flick the foot to try to stimulate a response, okay? And then what kind of activity? Is the baby moving around on its own, limited movement, or is the baby flaccid? And flaccid's like the, like a rag doll. And then what is the respiratory effort? If the baby has a strong, loud cry, that's always a good sign, right? Because that means that's exercise. The baby can't go for a run, right? So the way babies get exercise and the way babies increase oxygenation is crying. Even though I know, 3 o'clock in the morning, it's like, but that strong, loud cry is the way that they get their exercise. So you want to hear that. If you see hypoventilation or irregular, in other words, the breathing rate is very slow or it's irregular. Now, there is some irregularity in newborns, we'll talk about in a few minutes, that is okay. But if it's really irregular, like periods of apnea that are lasting more than 10 or 15 seconds, you're worried. And then, of course, if there's no respiratory effort. So we score each of these and we come up with a total. And then you can see at the bottom, this gives you what's normal, what's depressed, and what's going to have to resuscitate this child, right? And the reason we do it twice is because sometimes 1 minute after birth, some babies are just a little blah, but then in 5 minutes, they're like, hey, I'm here, right? So we want to give the baby the benefit of the doubt, okay? And so there are the scores. 8 to 10 is normal, 4 to 6, moderate, 0 to 3, the baby's not breathing. Normal measurements, and again, I hate the word normal, but 6 to 10 pounds. Anything greater than that, 9 or 10 pounds or larger, now 9-pound babies are getting more common, right? They're ubiquitous. But greater than 10 pounds, that is a macrosomic baby. That's macrosomia. Big baby is usually due to gestational diabetes. And here's the worrisome thing about a very large or macrosomic baby is it's usually hypoglycemic. Can you please mute whoever's not muted? Thank you. So macrosomic baby, big baby, low blood sugar. So people sometimes get that confused. Mom's blood sugar is high. Baby's blood sugar is low. And that's what you're worried about with a macrosomic or very large newborn. Length can be anywhere from 18 to 22 inches, and then head circumference, chest circumference. Meds. You need to know vitamin K, phytonadione, is given intramuscularly in the vastus lateralis. That's the first thing that we're going to give them, that and their ophthalmic antibiotic. These two drugs. The vitamin K prevents hemorrhage because baby has an immature liver, newborn. We don't want the baby having any hemorrhages, and it doesn't have any vitamin K stored in its liver, so we'll give it some. And then ophthalmic antibiotic, and it's usually an ointment, and it's usually erythromycin, but doesn't have to be. And that is to prevent newborn blindness. If there's anything infectious in the birth canal, it can actually infect the newborn's eyes and cause, visual loss, blindness. PKU level is done within 24 hours after feeding begins. They don't really even do the Coombs tests anymore, so I'm not going to talk about that. Immunizations, they do the hepatitis B first immunization before the baby leaves the hospital. Before the baby leaves the hospital, okay? So immediately is the vitamin K and the ophthalmic ointment, and then before the baby is discharged, That first of a Hep B series is given, okay? And then what should this kid look like, right? Here you go. The fontanelles, the soft spots, right? The baby is going to have these soft spots. If the baby didn't have them, its head would not be able to mold and fit through the birth canal, right? And it would, be crushed. So, baby's going to have soft spots. The soft spots should not be sunken in. If they're sunken in, that's a sign of hypovolemia or dehydration. And they shouldn't be bulging. If the soft spots are bulging, that's a problem. That can be hydrocephalus, sometimes too much fluid, but those are both signs of problems, okay? So here's what a normal baby should look like. It should be nice and pink. It should be crying nice and loudly, well flexed and full range of motion. The fontanelles are kind of shaped like diamonds, and the one in the back is like a triangle, right? There you go. See, there's the posterior, and there's the frontal. The mouth, you're always going to look at the baby's mouth. You're looking for cleft lip or cleft palate, and that's very observable. You can't miss it. Respirations, you have to listen to the baby's lungs, make sure that they're clear and the baby's breathing. Heart, you're listening for a murmur. In a newborn, if a murmur is heard, then that can be a atroseptal defect. In other words, a hole in the heart. So what can happen is, as the heart is developing, the septum, which is the wall in the middle of the heart that divides the left from the right, instead of fully developing, there's a part of it that's still open. They call it a hole in the heart. And you will hear a profound murmur, a whoosh. So when you hear lub-dub, you'll hear lub-shtum, lub-shtum. You're hearing the blood flowing between the left and right side. You don't want to hear that. The umbilical cord, it should be intact. And remember AVA. AVA, artery, vein, artery, right? So there's two arteries, one vein, and it should be clamped. The extremities should be the same length, and they should have 10 fingers and 10 toes. We joke about that, but the genitalia, the males, a baby, a newborn male, the testes may not have dropped into the scrotum, but they should be palpable. And with a female baby, a little discharge of blood or mucus from the vagina is normal, okay? It's normal, and it's because there is an exchange of blood flow between mom and baby, especially during delivery. And mom has hormones. And so some of them will, transfer into baby, which will cause that little bit of discharge. No big deal, okay? And then also I'm going to throw this in when we talk about immunity. And remember, passive, naturally acquired immunity. The newborn will have passive, naturally acquired immunity. Temporary immunity for a give or take 4 to 6 months after birth. Because of that exchange of blood, the antibodies that mom has, well, baby's going to have some of them floating around. They don't last forever. That's why we start immunizations relatively quickly. But, the baby will have a certain degree of immunity based on whatever mom is immune to for about 4 to 6 months after birth. And then when we talk about complications during delivery, meconium aspiration. So meconium is the first bowel movement the baby has. And that's not supposed to happen until after the baby is out, right? If it happens in utero, then there's a very high risk that the baby will aspirate, breathe in the meconium into the lungs, which can cause an aspiration pneumonia. So, and a sign of that is the discharge or the amniotic fluid looking blackish or greenish in color, okay? If during delivery the cord comes out first, well, you're going to have significant cord compression while the contractions are taking place, which means that while the baby's still inside, cutting off the blood flow, oxygen, and all that to the baby, right? That's the cause for a cesarean section sometimes. And then a breech presentation or a limb presentation and postpartum hemorrhage, which we talked about, okay? So that is part of newborn assessment. Let me pause my share for a moment. And I'm also going to pause the recording. Any questions about any of this so far?
Well, I must be the only stupid one this morning, but that's okay. Cord presentation, is that one of those where you put your hand in there and release the pressure and you stay there until they tell you you're allowed to move?
Yeah, you can do that,
Okay.
absolutely. The board
Okay.
won't ask you about that type of an intervention, right? But yeah, you're absolutely right. It all depends on where are we in the labor process. How dilated is mom? Do you know what I mean? So, there's so many what ifs. That's why I always say math is easy because it's black and white, but medicine is harder because it's not. If you ask me a question, I have to ask you 20 questions before I can give you an answer. And even when I give you an answer, it's probably going to be, well, if this is what's going on, then we might do that. Or if this is what's happening, then we might do this. Right? So that's the complexity. It really depends on where we are in that stage of labor. As far as, is mom fully dilated and the baby's head is crowning and then part of the cord is, relieve the pressure, get the kid out. Sometimes they will use a vacuum extractor, or they don't use forceps anymore. Back in the day, forceps looked like big old salad tongs, and they can insert one and then the other, and then they clip together. And when you squeeze them, it goes around the baby's head, and we can pull the baby out. If it's not done right, we can cause damage, right? Vacuum extractor is just like it sounds. It literally is a vacuum, and it's got like a suction cup with a vacuum hose. The suction cup is placed on the baby's head, and it's got to be placed just so, like not over the fontanelles, right? And then the vacuum helps to guide the baby out of the birth canal. That's the vacuum extractor. Vacuum extractions are used sometimes even with cesarean sections, because the research-based evidence or evidence-based research has shown us when mom's having a cesarean, and I've watched a few of them, they're crazy. I'm going into your uterus and I'm pulling this baby out, usually a transverse incision. And once you're opened up, they'll take bowels out and move them out of the way. Give me the uterus, get this kid out. It causes a lot of gas, a lot of pain postoperatively. Using a vacuum extractor with a cesarean decreases postoperative complications like hemorrhaging and decreases post-op gas and post-op pain. So that's just more FYI than anything else. Okay, just make you smart. All right. And I will talk about the trisomies real quick and about tetralogy of Fallot and PKU. And then, that's pretty much most of your, maternal newborn stuff that you need to know. Tetralogy of Fallot, that's fun. That is a congenital anomaly. And here, I'm going to pull up a cheat sheet for this one. And I'm going to share my screen. I'll put this up as well. This is it. It's kind of easy. It's named after Fallot. Fallot's the doctor that discovered this. You have several things going on. There is a hole between the chambers, right? So, and this is a ventriculoseptal defect usually. So between the two ventricles, there's a hole, and there's blood that is exchanged, deoxygenated and oxygenated. Not good, okay? Usually the aorta is just above the hole, not where it's supposed to be, okay? There's a thickening of the wall of the myocardium around the heart. There is an underdeveloped artery to the lung. See how that's narrowed? And this really narrow, so the blood is just not getting where it needs to get. It's impinged blood flow, all right? I'll put that cheat sheet up for you guys. And we're almost there. The trisomies. Let me stop my share. I'm going to talk. I have to find a cheat sheet for this. Tri meaning 3, somi, chromosomal. So you have, like I said earlier, there's 23 sets of chromosomes. Sets. So in other words, In one, there's 2 chromosomes, one from mom and one from dad, so on and so forth. The first 22 are genetic material. The 23rd set is the sex, so it's either XX or XY. In 1 through 22, a lot of stuff can go wrong. And the most common one to talk about is trisomy 11. That is also known as Down's syndrome. And with trisomy 11, instead of having just the 2, there is a repeat of an additional chromosome. So there's 3 at the level of the chromosomes numbered 11. Okay, so instead of 2, there are 3. And that causes some either mild to profound cognitive and also, physiological, I'll call them changes, right? And they are usually visible immediately after birth. The ones that you need to understand and know about, palmar creases. Everybody, if you look at the palm of your hand, let me try to get that up at the screen. Everybody, I can't say most, everybody has 3 creases, see? And if I were a palm reader, I'd be like, oh, my lifeline is really long. Anyway, people with trisomy 11 with Down syndrome have 1. Okay, they have 1. And then there are features that are noticeable, and they have to do with the eyes. And I will pull up a picture for you guys right now because a picture is worth 1,000 words, right? But definitely remember that about the palmar crease. That's important to know. Do advanced. Let's go back to good old Google. And I'm just going to put in here trisomy 11. Oh, I'm sorry, 21. There you go, my bad. If I said 11, that was 11 on the brain because I know someone who just had an 11. So 21, that's Down syndrome. When you look at them, let me see, what website is this? We want to go to, Children's Hospital of Philadelphia. Whenever you see a website that ends in .edu or .gov or .org, it's usually a credible website. Okay, so let's go here to CHOP, Children's Hospital of Philadelphia. And trisomy 21, Down syndrome, affects about 5,000 babies every year. Trisomy 21, extra chromosome, we talked about this already. And Down syndrome, what are the risks for medical problems? Congenital heart diseases, GI diseases, musculoskeletal problems, movement problems, endocrine, epilepsy, hearing loss, speech apraxia, and it's difficulty making the sounds required for speech. Sleep disorders, feeding disorders, developmental disabilities like learning and intellectual disabilities, and even autism to different degrees, and there's a spectrum. So Down syndrome occurs, there's an extra copy of that chromosome. The older you are, as far as being a female, when you age, remember, your eggs are getting older too, right? And so older than 35, you want to have the prenatal genetic testing done to make sure that there aren't any problems, Although, let me just tell you that women have babies. I think the oldest woman was in her 60s, which is insane to me, but it happens. Here are your symptoms, okay? Those distinctive facial features, the disabilities, respiratory infections, they're floppy, right? Their joints are kind of weak and floppy muscles. Baby's quiet, doesn't cry much. The little finger can be curved inward, and there's a wide space between the great toe is the big toe, wide space between the great and second toe. And there is a single deep crease on the soles of the feet and either one or both of the palms of their hands, okay? So that's important to know. Not going to go through all the other trisomies. They're trisomy 1, 2, 3, 4, 5, 6, 7, 8, 9, all the way through 22. And then with 23, those are the XX and XY congenital anomalies. We don't need to go through those. I'm going to pause the. Okay, so now we're going to talk about Erickson's stages of development. And this is something that you definitely need to know. He's right up there with Maslow, okay? But Erickson's focused on psychosocial development. So at what age should we be feeling what way, basically? When you look at the chart, you know, from infancy to about 18 months, you've got trust versus mistrust, right? This is important because if you have neglect in a newborn where cry, and no one comes, that is going to lead to this mistrust, like no one's coming when I'm crying. Think about, for those of you that do have children, babies, 8-month-old, 9-month-old, 10-month-old sits in the high chair. You give him something, he throws it on the floor. You pick it up, you give it back. He throws it on the floor. You pick it up, you give it back, he throws it on the floor. And you're like, why are you doing this to me? That is just kind of almost an experiment. That's not even a conscious experiment. Are you going to be there for me? Trust versus mistrust. Okay. Then early childhood, 18 months to about 3 years, is autonomy versus shame and doubt. I'll use this one as an example. You can't potty train an infant. You cannot. Okay. I have seen people make the attempt. I'm going to potty train this kid as soon as she turns 1. Please don't do that. Right? You can't potty train a 12-month-old. All right. They don't have the ability to understand and process logic and rational thought. Right. And so if you potty train them too early, that whole shame and doubt thing is what you're actually perpetuating versus the autonomy. Okay. Preschoolers 3 to 5, initiative versus guilt. And I mean, you guys can read the chart. The ones that you really need to know about are the trust versus mistrust. Okay. The initiative versus guilt. And this in regard to death and dying. ATI loves to ask questions about, a preschooler or a school-age child, mostly preschooler, where a family member has died. And the thing with that age group, 3 to 5, they will feel like it's their fault, maybe. Maybe I did something and that's why he died, right? So that's important to know. And then when we get to the older adult, which is considered 65 up through death, integrity versus despair. So what you want is you want to be able to look back on your life with acceptance, no regrets, right? If not, then you're going to be in that state of despair. When you see these patients or these residents in nursing homes that are the difficult patients, she's always on the bell, he's nasty to everybody. You have got to stop for a minute, look in your heart, and try to find the understanding. Is that the way you want to spend the last years of your life? That's the despair. Okay? So make sure that you understand that. I say this all the time, guys. Life is chaos. Be kind. Okay? All right. On that note, I'm going to take a break. Stop sharing, stop recording, and ask it. Okay, so we are back with boot camp. This is going to be the fundamentals portion of the program. Way back in term 2, that was a million years ago. So I'm going to share my screen with you and just go over the basic things that you need to know as far as fundamentals are concerned. So let me share my screen. And we're going to talk about, first let's talk about anatomical directions and patient positioning. And you do need to know just the basics of anatomical directions, right? When we're talking about a patient in the anatomical position is upright, palms forward, right? This is midline. Proximal is closer, distal's farther away. Superior is the upper portion of the body, inferior is the lower portion of the body. We have medial and lateral. Lateral, the outer sides. Medial are the inner sides. And then we have anterior, and the back is posterior, also known as dorsal. And with the feet, right, just make sure you know that the top of the foot is the dorsal aspect of the foot. The bottom or sole of the foot is the plantar aspect of the foot. That is the only part of the body where this is considered dorsal instead of anterior, okay? All right, so that's that. And again, all the cheat sheets that I pull up, I will share with you. So you will see every single one of them. Patient positioning is the next one, and directions of movement. And this is important to know, right? Everybody, I think, knows supine versus prone, okay? You have right lateral recumbent and left lateral recumbent, which means the patient is lying on their side, right? And knees are bent just a skosh. Fowler's position, straight up, okay? Maybe leaning a little bit backwards, okay? Legs can be straight, legs can be bent. Trendelenburg is where you have supine, but the head is lower than the feet, okay? And abduction and adduction, to me, this was easy to remember because when you adduct, you bring things together. You add them together. When you abduct, you bring them apart. Flexion, right, is bending a joint, reducing the angle, right? And then extension is, just like the name implies, extending it and you increase the angle. There's medial and lateral rotation. And just think about it. With medial, that's going inwards towards the medial side, lateral rotation, outside. And then we have supination and pronation. Supination is the rotation of the arm so that the palm is facing forward. And pronation, like prone, is where the palm is facing backward or down. Okay, that's pretty easy, right? Okay. And then here are the positions and then things that they're used for or nursing concerns with regard to them. So we've got high Fowlers, Fowlers, and semi-Fowlers. I feel like this is something that's pretty helpful. And it gives you, this cheat sheet gives you, you know, what the degrees are of the head of the bed and what they're good for and what they're not good for. So a good example, high Fowlers, great for breathing, bad for pressure sores, right? And Fowlers were semi-Fowlers, right? You know, semi-Fowlers great for neurological things like increased intracranial pressure. You never want your patient flat or supine. Supine, lying flat on the back, you know, not great for breathing. Prone, very few indications for prone, but after an amputation, just remember that post lower extremity amputation to prevent a hip flexion contracture, putting the patient in a prone position every few hours is necessary for the first post-op few days, okay? And then you've got Trendelenburg, where the head's down, the feet are up. Just so you know, this will bring somebody's blood pressure up pretty quickly if you need to do that. When you get somebody's feet higher than their head, that will raise blood pressure. So if somebody's got really low blood pressure, that'll help to jack it up. And then reverse Trendelenburg, which, you know, is the whole entire bed, not the patient's upper body, but the whole entire bed, where the head and upper part of the body are higher than the feet, okay? So there's that. Tell me you're not having fun. And then we're gonna look at, let's look at oxygen. So oxygen delivery equipment, okay? So nasal cannula is good for somewhere between 1 and 6 liters a minute. Even some will say 8 liters a minute. Don't worry about the percentage of oxygen, right? But nasal cannula here, that's 1 to 6. If the patient's nares become dried out, you know that you never, ever, ever use anything like petroleum jelly or anything like that because that is, you know, combustible. You can get a humidification unit and put it on the oxygen concentrator to help moisturize or humidify the air. Then we have a simple face mask. Simple face mask, if we need a higher percentage of oxygen, or it's also good if the patient is mouth breathing. Doesn't say it here, but that's important to know. So it's still going to give you that flow rate of about 6 to 10. but there are some perforations on the side. It lets CO2 get out, and it's good for humidification. It's good for mouth breathers. Then we have a non-rebreather mask, okay? If somebody needs a really high percentage and a high flow of oxygen, a non-rebreather is a great way to do it. They can get up to 100% pure oxygen with a non-rebreather. And this, I love this chart because this chart gives you here, if both flaps on the side are removed, which is, like a simple mask, then it results in a lower oxygen. If one flap is removed, higher percentage of oxygen. So when we talk about a partial rebreather versus a non-rebreather, with a non-rebreather mask, both flaps on the side are closed and in place, which means it prevents any other room air getting caught in there. So they're getting 100% oxygen, right? If the flaps are removed or open, or one flap is open, that would be a partial rebreather, okay? And then we have our good old Venturi mask. And when you look at a Venturi mask, it's the one that's got the almost corrugated tubing coming down. You'll see these in ICU. These are used where we need a very precise titration of how much oxygen this patient needs, okay? The flow rate isn't, exceptionally high. It's 4 to 8 liters a minute. But if I need to know that the patient's getting specifically 35% FiO2, this is the mask for me, okay? They call it a Venti mask or Venturi mask. So there are your oxygen delivery systems. Just make sure that you know when it comes to oxygen, if the patient has oxygen at home, they will have oxygen tanks. Oxygen tanks should never be stored on their sides. They should always be upright, okay? There should be no smoking signs pretty much everywhere so that people know not to smoke because there's oxygen present and in use. And they make now colored tubing because one of the biggest hazards with home safety is patients that are on O2 at home, they'll have that clear tubing and sometimes they'll have 100 feet of it so that they can move about the house. Remember, the longer the tubing, if somebody has a nasal cannula and they're getting, say, 4 liters from their concentrator, if they're, if there's 20, 25 feet of tubing, they're getting 4 liters. If there's 100 feet of tubing, they're not getting 4 liters. Because think about the pressure of the air, the oxygen trying to go through 100 feet of tubing. And so it's probably going to be a little bit less than what they should be getting. And there's the risk that they trip over the tubing, which is the reason for the coloring now of the tubing, like bright blue and bright red and stuff like that. So that's oxygen. Let's talk a little bit about clinical assessment. And this is something that I just put together just for the basics, right? Edema. Edema is the retention of fluid, okay, in either the body or the extremities. Edema is either pitting or non-pitting. If it's non-pitting, then you don't give it a number, okay? Pitting edema is when you take your finger and you depress the area, and then how deep does it go and how long does it take to come back up? And that's how we go. It's +1, +2, +3, +4. Okay, so this chart will help you better understand that. And there are some pictures of pitting edema and what it looks like. And I mean, with +4, you're pushing down, it'll go down like 8 millimeters, which is pretty deep. And it can take a minute or more to come back up. Okay, so pulse points. You want to make sure that you know your pulse points. So number 1, the rate. Whenever you're assessing a pulse, you can count the rate for 30 seconds and multiply it by 2. But when you're doing an apical, please always 1 full minute, and you should know 60 to 100 beats per minute is normal, within normal range. When you're assessing all peripheral pulses, we're talking about the dorsalis pedis or pedal pulse that's on the top of the foot, posterior tibial, kind of behind the ankle, popliteal, behind the knee, femoral at the inguinal area, carotid at the throat, radial at the wrist, and brachial up close to the shoulder. When you're assessing pulses, the documentation is universal, okay? And that means you're grading the strength of the pulse. And it's graded in numbers, 0 to +3. +3 is bounding. +2 means you're getting a nice, pretty much normal pulse. +1, weak, maybe thready. And 0, it's absent. And whenever you're doing a head-to-toe assessment, you should always do an apical pulse, because with older people, especially, what you hear in their chest is not what you will hear or feel, rather, at their radial pulse. And do not use a pulse ox on the finger to get your pulse. Please listen to their heart so you can hear if there is something wrong. Okay, it's very important to do that. There's a picture, gives you your common pulse points, where they are. Make sure you know them. Okay. And then muscle testing and function. When we're, it really irks me when I read nurses' notes and they'll say, like, good strength or a little weak. What is good? What's a little? So when you're assessing muscle strength for upper and lower extremities, this is the chart that we use. Just like the pain chart. The pain chart's universal. 0's no pain, 10's excruciating pain, give it a number. And any nurse or doctor that looks at it has understanding of that scale. This is the same thing. So when you are checking upper extremities, okay, you would document it as, say, bilateral upper extremities, 5 out of 5. If they have full range of motion against gravity and maximum resistance, you can read the chart. Or if there's a contraction, or if there's weakness, right? Or they don't have range of motion, or there's your chart. That's how it's documented. And when you are assessing this for a patient, say the patient is in bed, you have the patient grab your hands and just tell them to squeeze. That talks to you about their strength. And then you can also push against their hands and tell them, push back as hard as you can, right? And that's resistance. Same thing with their lower extremities, only you do it with your hands on the palms of their feet, right? And have them push against you. And it's documented with whatever the number is, slash out of a possible 5. Okay, so that's that. All right. And then, wait, there's more. Crutches. Everybody loves crutches. And it's easy to remember upstairs and downstairs, because you just remember up with the good and down with the bad. But when we talk about gaits, okay, this looks like a learn how to dance quickly chart. These are crutch gaits: 2-point gait, 3-point gait, 4-point gait, and a swing through or tripod gait. Okay. And ATI loves to give you these questions in words. Instruct the patient to take the unaffected leg and put it forward, and then take the affected leg. They make it, I feel, a little difficult, and it doesn't have to be, okay? Depending on if the patient is partially weight-bearing or non-weight-bearing, these are the gaits that you would use, okay? Please mute yourself, whoever's not muted. Mute. Thank you. Okay. So these are your crutch gaits. I will put this one up for you guys also. Okay, let me pause. Okay, let's talk about drains. Share my screen. All right. And so there are surgical drains. The two that you need to know are the JP, Jackson Pratt drain, and then the Penrose drain. The Penrose drain is considered an open drain. So you have what looks like a rigatoni that's coming out of the patient, and it's got a safety pin that keeps it in place. And then there's either gauze or an ABD pad, so that whatever's coming out of that incisional site is draining into the gauze. That's considered an open drain, okay? A JP is considered a closed drainage system, okay? Because what you have is you have this clear bulb, and actually I'll pull up this picture because that's a real one. You have a clear bulb, and it's got a tube that is held in by 1 or 2 little sutures at the incisional site, helps to drain out excess blood and lymphatic fluid to prevent wound infections. The bulb, okay, and here, this is a good one. This, my next door neighbor, Cindy, has 2 of these from her bilateral mastectomy that she had. And so you've got an entry site here held in by a suture. This is a little reddened, but it doesn't look bad, right? You're going to see a little crusty crust, just like somebody with an external fixation device. That's not unusual. There's your tube that goes to this bulb that has calibrations on it. When the bulb starts to become full, you clamp the tubing, you open up the top of the bulb. When you open the bulb up, air will rush in, and you will then be able to look, and you always hold the bulb up at eye level. And actually, let me stop sharing for 1 minute and emphasize this point. When you are measuring liquid medication, when you are trying to eyeball the amount of fluid in a container, how much urine is in this urinal, how much drainage is in this JP bulb, you need to hold it at eye level, because if you're looking down at it, you're not going to be able to see the calibrations in a way that's necessary to be accurate. Eye level, okay? And so you look and you say, all right, there's 30 mils of, sanguineous drainage, which is bloody drainage, or 30 mils of serosanguineous drainage, okay? You would empty the drainage out, and then you take that bulb and you compress it, you squeeze it, and put the cap back on. By doing that, it stays compressed, and now it's got a little negative pressure, so it's kind of gently sucking on that incisional site and pulling the excess fluid out. So that is a JP drain. And let me just show you the picture one more time. So JP is considered a closed drain because we're collecting the drainage. Penrose is considered an open drain because we're not collecting the drainage into anything. It's just a piece of gauze. And this is a great little picture too, which I am actually going to copy that image, and I'm going to put it into my clinical assessment cheat sheet. See, why reinvent the wheel, right? Work smarter, not harder. Okay, so those are your drains. Okay, save that so I don't lose it. And then let's talk about trachs, because everybody loves trachs, right? Let me get to remember, tracheostomy care, tracheostomy suctioning is a sterile technique, okay? It is a skilled thing that only nurses can do, okay? And you may have a question about tracheostomy care or tracheostomy suctioning, okay? Come on. Okay. This is a great little diagram. You gather your equipment, you open your sterile package, and remember, anything that you're opening that's sterile needs to be waist high or higher because you can't bend over it. And you always open the first flap away from you, okay? With a trach, there is a little neck plate. There are ties that keep it in place, usually a drain sponge, and then there's a cannula. Cannulas now are disposable, but there are still some that you must clean the inner cannula, okay? And if it's one of the old school ones, the cannula comes out, and then you have a little container that you would pour your sterile solution in, normal saline with a little brush. You cleanse the cannula, make sure that it's nice and clean. You would then clean around the neck plate, and underneath the neck plate, you leave the old ties in place. You replace the cannula, and then you put the new ties on last, and then remove the old ties, okay? Because there have been instances where take off the old ties and there's nothing holding it in place, patient moves and the whole neck plate and the whole thing comes out. You don't want that to happen, okay? That is a sterile technique. When we talk about suctioning, the cardinal rules of tracheostomy suctioning, you hyperoxygenate the patient prior to the suctioning, and that means 100% oxygen, either via the mechanical ventilator or via an ambu bag, okay? And that is because when you are actually suctioning the patient, they can't breathe, right? Suctioning should never last any more than 15 seconds. 10 to 15 seconds is the maximum. And when the suction catheter is placed into the cannula to suction, let me get a picture of this also so that I can show you. Get rid of this one and let me get a suctioning picture. And we'll talk about, endotracheal and orotracheal. Okay, so with suctioning, there we go, look at that. Your suction machine is on the wall. You're gonna hook up your sterile catheter to the wall suction, okay? Here's the trach, okay? There's a thumb control. This is going to be where you insert the catheter, right? Gently but quickly. And then as you are removing it, your thumb will intermittently suction on the way out, right? So you'll have your thumb moving quickly, suctioning on the way out, okay? So you don't want to suction on the way in, you suction on the way out, 10 to 15 seconds. And suctioning is going to be your last resort. If the patient's awake, alert, and oriented, you try to get them to maybe deep breathe and cough if you're worried about secretions. But if secretions are copious and extremely viscous, or there's a mucus plug, then, sometimes you got to suction. So I'll get up some more pictures of suctioning and suctioning techniques, and I'll put those in that clinical assessment sheet to help you guys out as well. Urinary catheters. Let me get some pictures of that for you guys. And really what I want to go over with them is just a couple things. Insertion of an indwelling urinary catheter. That is also a sterile technique. By the way, while I'm talking about this, wound care is not a sterile technique, okay? It is not a sterile technique. There are some instances where you would want to use a sterile technique for specific types of wounds. However, generally speaking, wound care is clean. It is not sterile, okay? And so, and I like to talk about the female because if you miss going into the male, maybe nursing's not for you. Anyway, so you have a catheter that is being inserted into the urethra, going into the urinary bladder, and there's a balloon that is inflated that holds the catheter in place. The end of the catheter has two ports, and one of them gets attached to a drainage bag of some sort. The other one is the port that you use to obtain a sterile urine specimen. You never get a urine specimen from the urinary drainage bag. That urine is contaminated, okay? And so there's a great video here, and this is from it's the American Medical Journal. I am gonna see if I can download this video for you guys and save it on my YouTube channel, and this way you guys can watch this. This is a real human. That's what you need to see, not just a mannequin, all right? So I'll get that for you. And then let me just show you the indwelling catheter and urine sample. Let me make sure I'm sharing the right screen with everybody. Here we go. Okay. When you are obtaining a urine specimen from, here you go, this is the picture I'm looking for. And I know the picture's small, but I'll copy it and make it big so that everyone can see it, and I'll put it in that clinical assessment, okay? You are going to take your hemostats, right? And you're going to clamp off the tubing, and it shouldn't take very long where there will be some urine stuck up in the tubing. You will then take your syringe, put it into the luer lock opening on the port, and you will be able to withdraw the urine, put it into a sterile specimen container, and send it to the lab, okay? You never get the urine from a drainage bag. And I've seen that done a bunch of times. And furthermore, when you are emptying a drainage bag, and most of them kind of look very similar, if not the same, there's a clamp that's released and the urine empties into a container, usually a calibrated container. After you empty the bag, you are supposed to wipe the clamp with an alcohol prep before you close it. And I tell people this all the time. I've never seen a nurse do it. Never. Not like, oh, once in a while. No, never. And that is that's the book way to do it. That's what you're supposed to be doing. Because we have an open route into this patient's bladder. And that is why patients with indwelling urinary catheters have the highest risk of UTIs, okay? Because they're not being cared for properly. So, and I'll put these pictures up for you guys as well. Let's see, sterile technique, tracheostomies, oxygen, crutches. I'm going to stop sharing for a minute and I'm going to pause. Okay, and when it comes to insertion of a urinary catheter, an indwelling catheter, a couple things to note. Number one, when you're doing a female, one of the steps included, and this is as per the book and as per ATI, instruct the female to bear down as if she's having a bowel movement. I will tell you guys straight up that in all the years I've been a nurse and thousands of indwelling catheters I've stuck in people, I've never once done that. However, it does make the perineum bulge a little bit, and so it should help like identify the urethra in the female. So, you know, female anatomy, you should know, you know, just in case. So, you know, if you've gone into the vagina, which happens a lot, accidentally, you won't be the first and you won't be the last to do it. If that happens and the catheter goes in the vagina, leave it there. That's your landmark. And then you know you have to go above that to find the urethra. The urethra is underneath the clitoris, okay? And like I said, if you miss on a guy, I don't know what to tell you. The other thing, there's a type of catheter that's called a coude catheter. It is a curved catheter. They're usually red in color too. They look different than regular urinary catheters. They are helpful if you are trying to catheterize a male who has a swollen prostate because the shape is curved and it can kind of go past that swelling. That's a coude. When it comes to catheterization, a post-void residual cath means maybe the physician or you are concerned about urinary retention. You have the patient void. After they void, you do a straight cath to see what the residual is after they have voided. Anything greater than 50 to 100 milliliters of urine, the doctor's going to tell you to leave the catheter in because that's retention. Okay. Anything under that, there's a little urine, that's no big deal. That is a post-void residual catheterization. Talked about the coude. And I think that's it. I'm sure there are a few more things I could add, but they're not coming to mind right now. But I think this was pretty comprehensive. So I am going to end the recording. And then for those that are here live, I'm going to see if they have any questions. So until next boot camp, peace.